and welcome to today's episode of the Central Ray podcast and our latest ARRT Radiography Registry review episode. In this series, we break down the ARRT Content Specifications to help you prepare for exam day with confidence. I'm your host Ryan Ross, and in this episode we are tackling one of the largest and most detailed heavy sections of the procedures category, head, spine and pelvis imaging. We will walk through the specific procedures covering positioning, anatomy, adaptation for patient condition, and how to evaluate your images for proper demonstration of structures. Whether you're a student preparing for your boards or a practicing tech brushing up for CQR, this episode is packed with practical insights. Let's dive in. Section 1, Head Procedures, and we will start with positioning. Head imaging involves projections of the skull, facial bones, mandible, TMJs, nasal bones, orbits, and paranasal sinuses. Positioning here is all about accuracy, as even slight rotation can obscure pathology. Common skull positions include apiaxial, known as the town, the lateral, the PA axial or Caldwell, and the submental vertex, the SMV, and the reverse Caldwell or reverse town for trauma. Facial bones often require Waters or modified Waters and Caldwell, while the orbits and nasal bones are similar. For TMJs, you will see modified Law and the Schuler, both axial lateral projections designed to visualize the joint space. Respiration is generally suspended during exposure to help minimize motion. The head anatomy. You are expected to identify both bony landmarks and important soft tissue structures. For example, skull, the frontal, parietal, occipital bones, the sella turcica, and the petrous ridges. Facial bones will be the maxillae, the zygomatic arches, and the nasal septum. Sinuses will be the maxillary, ethmoid, sphenoid, and the frontal sinuses. Understanding these help in assessing trauma, sinus disease, or congenital abnormalities. So taking a closer look at the actual cranial bones, the skull has 8 cranial bones. The frontal is the forehead and the superior orbits. The parietal, of which there are 2, contains the lateral walls and the roof. The occipital is the posterior and it contains the foramen magnum. The temporal, again one on either side of the skull, includes the mastoid and the petrous portion. The sphenoid is the base of the skull and it has the sella turcica. And then you have the ethmoid, which is part of the nasal septum and the medial orbits. Facial bones. There are 14 facial bones, including the nasal, where there are 2, the lacrimal, again 2, zygomatic, maxillary, and palatine, again all having 2. You have the inferior nasal conchae, again with 2. Then you have the vomer and mandible. And looking at some of the important landmarks, you would be asked to identify and use the following landmarks. The glabella, which is the smooth area between the eyebrows. The nasion, which is the slight depression at the bridge of the nose. The acanthion, the base of the nasal septum. The mental point, known as the chin. The gonion, which is the angle of the mandible. And then the outer and inner canthus, or the corners of the eyes. And then the EAM, which is the external auditory meatus, or otherwise known as the ear canal. We also have to be familiar with the positioning lines, and these are imaginary lines that are between 2 structures to help with positioning. We have the OML, the orbital-meatal line, and that extends from the outer canthus to the EAM. You have the IOML, which is the infraorbital meatal line, and that goes from the infraorbital margin to the EAM. The AML is the acanthomeatal line, and that goes from the acanthion to the EAM. And then the mid-sagittal plane, or MSP, and that divides the head into the left and right halves. So looking at some procedural adaptations, when imaging the head, you may need to adapt for trauma, limited mobility, or even pediatric patients. Trauma, you always look to use the horizontal beam for laterals and reverse projections to avoid moving the patient's head. Pediatrics, you want to have faster exposure times and have immobilization devices to help keep the head still. And then we are looking for pathologies such as fractures, swelling, or post-surgical changes that may require some modified projections. The evaluation of structures. So when reviewing images, we need to check for correct alignment of central ray, the part, and image receptor. Now let's talk about one of the most critical and sometimes overlooked aspects of evaluating head images, checking for rotation and tilt. When it comes to the skull, symmetry is your best friend. On frontal projections like the PA, the Caldwell, or the Waters, start by comparing the distances from the nasal septum or the midline structures to the outer margins of the skull. Those distances should be equal on both sides. If one side is narrower, that's the direction the head is rotated towards. For the lateral skull, it's all about superimposition. Look at the orbital roofs and the mandibular rami. Those structures should be perfectly stacked, one on top of the other. If the orbital roofs aren't aligned vertically, that would suggest tilt, meaning the top of the head is angled towards or away from the receptor. If the mandibular rami or posterior margins of the cranium don't line up horizontally, then that would indicate rotation, the head being turned from either the left or the right. On SMV and Waters views, symmetry of the mandibular condyles, the rami and maxillary sinuses will tell you if your patient was centered correctly. Again, unequal spacing on either side is a red flag for rotation. Now let's take a look at the spine anatomy and the terminology. The spine is divided into 5 regions, and this would be the cervical, the thoracic, the lumbar, the sacrum, and the coccyx. The cervical spine has 7 vertebrae, with C1, commonly known as the atlas, supporting the skull, and C2, the axis, featuring the odontoid process, or otherwise known as the dens. C7 has the vertebra prominens. The thoracic spine has 12 vertebrae, each articulating with a pair of ribs. The lumbar spine has 5 large vertebrae that bear much of the body's weight. The sacrum contains 5 fused segments, and the coccyx is 3 to 5 fused bones. The cervical and lumbar regions have lordotic curves, while the thoracic and sacral regions are kyphotic. Key structures include the zygapophyseal joints, the intervertebral foramina, and intervertebral discs. Important terminology to know includes lordosis, kyphosis, scoliosis, and pars interarticularis. Looking at positioning, the landmarks, body position, central ray, aids, and respiration. For the cervical spine, the AP axial projection uses a 15 to 20 degree cephalic angle to visualize disc spaces, with the central ray at the C4 and respiration being suspended. The lateral projection demonstrates the zygapophyseal joints. The central ray is horizontal and at C4. The open mouth odontoid should show C1, C2 with the patient's mouth open and the central ray passing through the center of the open mouth. Obliques demonstrate intervertebral foramina. Anterior obliques show the downside, whereas posterior obliques show the side up. Flexion and extension laterals are performed to assess instability. A swimmer's view demonstrates the cervico-thoracic junction, useful for when the shoulders can obscure C7 or T1. For the thoracic spine, the AP projection is centered at T7 with suspended respiration. The lateral projection shows intervertebral foramina. A breathing technique may improve visibility of vertebra by blurring the lung field. A swimmer's view can also help when the upper thoracic vertebrae are obscured. For the lumbar spine, the AP is centered at L4 to L5 with the patient's knees bent. The lateral shows intervertebral foramina. The L5-S1 spot focuses on the lumbosacral junction. Lumbar obliques demonstrate zygoapophyseal joints with the downside being visualized. Flexion and extension laterals assess stability. The sacrum and coccyx are imaged with AP axial and lateral views using appropriate angulations. And when linking this to radiation safety, a scoliosis series may be performed PA to minimize patient dose. Positioning aids such as sponges, sandbags, or immobilization devices can improve stability and comfort. Respiration, as we had mentioned before, is typically suspended on expiration. Procedure adaptation. Patient condition often dictates adjustments. In trauma, again using the horizontal beam for laterals are crucial to avoid moving the cervical spine. For patients with limited mobility or pain, use supports and minimize repositioning. In pediatric patients, immobilization devices and reduced technique are appropriate. Bariatric patients may require increased exposure and careful centering. Evaluating the displayed anatomical structures. On cervical images, the entire cervical spine from the base of the skull and the upper thoracic region should be visible, with open joint spaces and proper alignment. On the odontoid view, the dens and lateral masses should be clearly visible. On thoracic and lumbar images, ensure that vertebral bodies are not rotated and joint spaces are open. Oblique images should clearly demonstrate the correct foramina or facet joints. Assess for symmetry, proper centering, and appropriate exposure techniques. Some of the pathologies for the spine. Traumatic injuries include the Jefferson fracture, which is a burst C1, a hangman's fracture, which would be a C2 pedicle fracture, a clay shoveler's fracture would be a spinous process avulsion. We can also have compression fractures and chance fractures. Degenerative conditions include spondylolysis, spondylolisthesis, and herniated nucleus pulposus, or HNP. Inflammatory and congenital conditions including ankylosing spondylitis, spina bifida, and scoliosis. The spine is also a common site for metastases and osteomyelitis. So to summarize, we have covered anatomy, positioning, patient adaptation, image evaluation, and common pathologies of the spine. Here are a few questions to test yourself. Which projection best demonstrates the cervical zygoapophyseal joints? In lumbar obliques, which side of the joint is visualized? And what fracture is associated with a hyperflexion injury? Pelvic anatomy and terminology. We will begin by reviewing the anatomy of the pelvis and the proximal femur. The pelvis is made up of two innominate bones, each composed of the ilium, ischium, and pubis. Together, they form the acetabulum, which articulates with the head of the femur to create the hip joint. The sacrum and coccyx articulate with the ilium at the sacroiliac joints. The pelvic brim divides the pelvis into the false pelvis above and the true pelvis below, which is more relevant in the obstetric imaging, but still important to understand. The greater and lesser trochanters, the femoral neck, and the intertrochanteric crest are key proximal femur landmarks. The term anteversion refers to the natural forward angle of the femoral neck, which we compensate for during positioning. Common medical terms you may encounter include the acetabulum, pubic symphysis, iliac crest, ischiotuberosity, and the obturator foramen. Positioning landmarks, body positions, central ray, aids, and respiration. The standard AP pelvis projection is performed with the patient supine, legs being internally rotated 15 to 20 degrees to correct for the femoral neck anteversion. The central ray is perpendicular, centered midway between the level of the ASIS and the pubic symphysis, or roughly 2 inches inferior to the ASIS. Respiration is suspended on expiration. Internal rotation is critical to prevent foreshortening of the femoral necks. Positioning aids like sandbags or supports may be used to maintain internal rotation. For a single or unilateral hip, the AP is performed with the same internal rotation and central ray directed at the femoral neck, about 2.5 inches distal to a line between the ASIS and the pubic symphysis. The lateral hip, also sometimes called the frog leg or Lowenstein projection, involves flexing the knee and abducting away the thigh 45 degrees. This shows the proximal femur and the hip joint in profile. Respiration is also suspended on expiration. In trauma patients who cannot move the affected leg, the cross-table lateral hip or Danielus-Miller projection would be used. The unaffected leg is elevated out of the way. The cassette is positioned parallel to the femoral neck, and the central ray is directed horizontally to the femoral neck. The Clements-Nakayama modification can be used when both legs are immobile. For acetabular fractures, the Judet views, which are posterior oblique positions, are performed by rotating the patient 45 degrees. The internal oblique shows the iliopubic column and the posterior acetabular rim. The external oblique shows the ilioischial column and the anterior acetabular rim. The AP axial outlet, or Taylor view, is used to evaluate the pubic and ischial rami, and with a cephalic angle of 20 to 35 degrees for females and 30 to 45 degrees for males. The AP axial inlet view assesses pelvic ring injuries with the central ray angled 40 degrees caudad. Procedural adaptations. Patient condition can greatly affect how these projections are performed. In patients with trauma, you may not be able to internally rotate the legs, which is why the cross-table lateral is critical. Patients with limited mobility, pain, or hip replacements may require modified positioning or the use of sponges and immobilization aids. In pediatric patients, be mindful of developmental dysplasia of the hip and use immobilization devices to minimize motion. For bariatric patients, you may need to increase technique settings, ensure a large enough field of view, and use appropriate centering to account for body habitus. Always ensure that the anatomy of interest remains visible while minimizing dose. Evaluation of the displayed anatomical structures. When evaluating your images, check for symmetry of the pelvic bones, the iliac wings, the obturator foramina, and the ischial spines should appear symmetric on an AP pelvis. The greater trochanter should be seen in profile, indicating proper internal rotation, and the lesser trochanter should not be prominent. For the cross-table lateral, the femoral neck should be visualized without superimposition. In Judet views, ensure proper rotation by evaluating the open and closed appearance of the acetabular columns. Misalignment, inadequate rotation, or improper central ray angulation can result in foreshortening or distortion, so always assess your image critically. Pelvis pathologies. Fractures of the pelvic ring can occur from high-energy trauma. Acetabular fractures may involve the anterior or posterior columns, with Judet views helping to differentiate. Hip fractures can involve the femoral neck, the intertrochanteric region, or subtrochanteric region. The femoral neck fractures are common in elderly patients with osteoporosis. Avascular necrosis of the femoral head appears as increased radial density and collapse. In children, leg calf Perthes disease is avascular necrosis of the femoral head. And that brings us to the end of our pelvis review. We've covered anatomy and terminology, positioning and landmarks, adaptations for patient condition, image evaluation and common pathologies. Remember to practice your positioning and review these concepts thoroughly. Before we finish, here are a few more questions. Firstly, why do we internally rotate the legs for an AP pelvis projection? Second, what condition in children includes or involves avascular necrosis of the femoral head? And thirdly, which projection, or which Judet-oblique projection rather, demonstrates the anterior acetabular rim and the ilioischial column? So thanks for joining me today on the Central Ray podcast. This concludes our 3-part series on the head, spine and pelvis regions. Keep studying, keep practicing, and remember, you're capable of mastering this material. Until next time, stay sharp and stay confident.